Dr. Venkatesh will be sharing his slide. Dr. Venkatesh is a Chief Medical Officer of Arvind Eye Care System, Pondicherry, and is a high volume surgeon and is looking after academics. And last year, I think he had the maximum number of publications from Pondicherry. Venkatesh, please.
Hello, friends. Welcome to our general program. I take this opportunity to thank my good friend Avanindra Gupta for asking me to talk about an innovative way of fixing SFIOL, which was developed by one of my good friend and colleague, Dr. Prabhu Bhaskaran. So this technique, we named it as XNet, where it is actually an extraocular needle-guided haptic insertion technique for sutureless scleral fixation of IOL. You all know the genesis of sutureless scleral fixation. Again, my good friend Dr. Gabard made this Chariot tunnel, and then he came up with an excellent way of fixing the PCIOL, especially the three-piece PCIOL, into the sclera, so that you don't have to fix it to iris or do a suture way of fixing it to sclera. So he did a sutureless way using a Chariot tunnel. And brilliantly, Dr. Amar Agarwal converted this technique into glued IOL technique. So because most of the people were finding it difficult to put the haptic into that scleral tract, the small point where you have to enter. So it was very difficult for many of the surgeons. So that is where innovation comes, making it simple. So under a scleral flap, so when you make a track here, it is very easy to insert the haptic and then glue the flap. So that is basically the glued IOL technique, and which became popular across the globe. And then came a brilliant idea, an award-winning idea in ASCRS. Now it's published and it's also adopted by several surgeons across the globe, called the Yamane technique, developed by Shin Yamane from Japan. So what he did was, he took a 26 gauge needle, and then he made a scleral track. And then after the track, he entered into the vitreous, and then you thread the haptic directly into the needle, and then you remove the needle so that the haptic does the scleral track also continuously. So you don't have to remove the haptic and then again insert it into the scleral track or the Chariot tunnel. So you can do this as one single step. Again, a brilliant idea, which became very popular, because any step which is difficult, if somebody makes it easier, then I'm sure it's a great innovation. But again, the problem here is the handshake, where you have to do the handshake inside. A lot of people who are not used to doing anything behind the pupil, especially in the anterior vitreous, find it very difficult. Like this, you try to shake, but she's not very comfortable. So it's very difficult for the handshake to happen, like you see here. So many of the times it can slip. You try to hold it with two of your forceps, but it can slip. So this sometimes can take a very long time for some surgeons. It can be so too long to kind of hold on to that to finally exteriorize the haptic. So these are issues with the handshake technique which still exist. So that's where the technique of XNet comes. So basically, what happens here is, whether you do a glued IOL or the Gabard way of doing it. So you insert the needle through the sclera behind the iris. No, it's actually a bent needle. At a certain angle, it is bent, and there is a small stopper also, if you see here. And then you exteriorize the needle. That's the best part in this technique. through the pupil, through the tunnel. You use your McPherson's forceps to gently open up the valve of your SICS tunnel. And then you exteriorize the needle and you thread the haptic here. So here you don't have to do a handshake. You don't have to make that step much simpler. And then you exteriorize the haptic and then you put a stopper. The stopper really keeps your haptic intact. So when you are manipulating on the other side, you will not lose this haptic inside. This happens for some people, and that is also really cumbersome sometimes. And the same you do from the other side. You exteriorize after you are doing this technique. And now it's up to you. If it's glued under the flap, or if you're doing a chariot tunnel, you have to really try to pull it back and then insert it into the chariot tunnel, and then you complete on the other side. So this stopper with the exteriorization really helps to make this simple, this complex procedure very simple. But the only issue is you need an SICS tunnel because you are doing with a rigid lens. It's not a foldable lens. So you're doing with a rigid PMMA 3-piece lens. Let's see how we can practice this in wet lab. So all the steps can be beautifully practiced in a goat's eye or even a cadaver eye in wet lab. The sclerotomy is like what you see is 1.5 millimeters. And then you use your McPherson's to open up the valve and then exteriorize the needle. And then you insert the haptic. You get it inside. And then one stroke, you exteriorize the haptic and you put the stopper. The stopper will make sure that the haptic doesn't go inside again. And then the same you can do. If the chamber collapses, you can put viscoelastic into the goat's eye, or you can even use formalin. And then you insert the haptic into the needle. And then this step is a little tricky. You have to gently go inside and then start exteriorizing it slowly. And when you come out, when the haptic comes out, you catch with the McPherson's and then you remove the needle. We have seen that this technique is really useful when you have corneal opacities. When the visualization is very poor, this technique is very useful. So this is the chariot tunnel being made using a MBR blade. And the chariot forceps really helps you to put the haptic into the tunnel. And you can see in this hazy cornea, you can beautifully bring the needle outside and then you can do the threading because it's so difficult to do inside when you have such a poor visualization. Here, after the SF5OL, they're going to transplant the cornea and you can see the stopper, the silicone stopper. Once the stopper is in place, then you remove the needle from the haptic, and the same you can do from the other side. So somebody can help you in positioning at this point because you have to do an acute bend of the haptic to insert into the needle. And then we need to gently externalize it. And then using a chariot forceps, you insert that haptic into the chariot tunnel. Following which a keratoplasty was also completed. So now this kit is developed by, I have no financial interest, Aura Lab now does it. It's called the XNet kit. You have in the back, you have markers, which is 4 millimeters and 1.5 millimeters to mark exactly. 4 millimeters is for the chariot tunnel. 1.5 millimeters is for the scleral entry. You have a nice finger grip. It's a 26 gauge needle, which is bent at exactly 40 or 45 degrees, where you need the bend for comfortable exteriorization. And you can see now the stopper is is a double stopper. So it is placed in such a way that even if you lose the haptic on one side, still the other end is intact. So that's another brilliant idea, which is now into this XNet kit. This is a double stopper or the double protection which you are seeing. So even if you lose one side, the other side is still inside. It is a magnified view. It's a 60-degree bend. This is a close-up of the double stopper. The close-up view of 1.5 millimeter mark and a 4 millimeter mark. And that's the kit which is now readily available. You can use one for your left side, one for your right side, because the kit has got both the ones, and then you can dispose it. It's less expensive. And the silicon stopper, this is how it works. The double protection works. So even if you lose one on one side, when you are manipulating the other side, still the haptic will be inside. Again, I take this opportunity to thank my good friend Avnindra Gupta for conducting this excellent instruction course in our virtual AIOC. Thank you.
Thank you, Dr. Venkatesh. It was a wonderful presentation. And I do remember there was one Surginar when this surgery was presented. The Surginar was conducted by AIOS, and Dr. Namta and myself were there, and your colleague had shown this technique. So this looks wonderful.
Dr. Prabhu, the innovator, was the surgeon for that day.
Yeah.
It was well received. I think it was one of the well-received surgeons in your period.
Yeah, absolutely. It was.
I remember seeing 21,000 plus views or something like that.
Yeah. So that was
a brilliant idea and technique which makes things much simpler for others. I mean, that is our duty as surgeons, as good surgeons. We need to make even an average surgeon do well. And that is what
Absolutely.
I think XNet has done. And of course, Blue Dye Well, again, to make that insertion is again another difficult part. So Blue Dye Well with the XNet would make anybody do comfortably a sutureless scleral fixation.
Absolutely.